This podcast is being recorded on the lands of the Wurundjeri and the Bunurong people of the Kulin Nation. We pay our respect to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders, past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest clinical guidelines and research in obstetrics and gynaecology through conversations with leading experts. Today we're unpacking RANZCOG's updated clinical guideline for intrapartum fetal surveillance. I'm Associate Professor Scott White. I'm a maternal fetal medicine specialist based in Perth, and I chaired the Guideline Development Group. Joining me today is Dr Penny Sheehan, who was a member of the Guideline Development Group. Penny, could you please let us know some more about yourself and your experience with intrapartum fetal surveillance?
I'm an obstetrician head of unit at the Royal Women's Hospital. Until recently, I have been working with Safer Care Victoria as the clinical lead for their maternity and newborn improvement team. I also am on stillbirth and research and reporting committees for the Consultative Council of Perinatal Mortality and Morbidity, again with Safer Care. I'm a clinical research fellow at the Pregnancy Research Centre at the Royal Women's, and I have published on scalp lactates in labour and their use and an RCT, and I've also been involved in RCTs of new technology in monitoring babies in labour.
Fantastic. It's great to have a real expert with hands-on experience in the field. Penny, before we get started, can you tell us, do you have any relevant conflicts of interest?
No conflicts of interest.
Excellent. Let's start by exploring how this guideline was developed. Penny, can you talk us through the process of the guideline development and how the implementation of the grade system contributed to the final recommendations?
So in our introduction statements at Safer Care, we always talk about how diversity is strength, and this was certainly an impressively diverse group. We had collegiality, we had midwifery colleagues, we had academics as well as straight clinicians, and we had representatives from regional as well as rural and metropolitan, and also from Australia and New Zealand. So a really diverse group. The group was provided with a very detailed review of the literature and the evidence, and we used the grade system, which is now used for all RANZCOG guidelines. And just, I'm sure people are familiar, but it's a structured, widely accepted framework. It's usually used for international guidelines. And I think it gives people an understanding of the logic that the guideline group used in developing their own statements and their recommendations. It's really important to consider the limitations of the evidence that we worked for, especially in this area. It's very difficult to conduct trials on fetal monitoring in a rigorous way. A lot of the evidence has still got quite a lot of uncertainty at the moment. Usually the group made strong recommendations where on the basis of moderate evidence, and conditional recommendations where the evidence was low or very low. And of course then we have our good practice recommendations, which cover, they make suggestions where the evidence is lacking.
Yeah, great. And some of those good practice suggestions covered things like, the guiding principles around fetal surveillance, and one of those new to this version of the guideline being informed consent. So what do those good practice statements say about patient communication and consent related to fetal surveillance?
So, fellows of the college and colleagues will be really familiar with this as an emerging area of importance in our field. And people will be familiar with the principles of shared decision-making and also respectful maternity care. And Safer Care has just published a new framework for respectful maternity care, which might be of interest. Look, it's really important that this discussion occurs between the clinician and the patient at multiple stages. I think, during the third trimester, the group agreed long before labour takes place. And then, of course, on presentation in labour and during labour, things can change. I think we used to rely on childbirth education a lot to inform women, and it was kind of local to services, and it included things about practice at the service. But now women are getting their information from so many different sources. I think it's really important to have the conversation. I think the group decided that women should have a discussion about the advantages and disadvantages of various forms of fetal monitoring with their clinicians who'll be looking after them. It was really important for us to consider all of the risks associated and the things that are of most importance to women. In these sort of conversations, you might find that for women, the most important thing is to be able to be in water, whereas for me, the most important thing might be to monitor this baby that I suspect of being small. So it's good to have that discussion between the two.
Great. There's some changes to the antenatal and intrapartum risk factors associated with fetal compromise and the way that they're presented. Talk us through the evidence-based recommendation the guideline provides.
For a start, we've got a table outlining antenatal and intrapartum risk factors, and it's divided into the strong and conditional evidence bases with an emphasis on it's divided into those groups on the basis of the evidence. It suggests continuous CTG monitoring be offered where risk factors have been identified.
Right. So one of the things that's been somewhat controversial in the way this guideline has landed is the way we've spoken about gestation of prolonged pregnancy. So the previous version of the guideline suggested a gestation beyond 42 weeks was a risk factor for fetal compromise, whereas the new guideline suggests that there's also an increased risk beyond 41 weeks. Why has this changed and what are the implications of this, particularly for models of care?
The evidence is clear that the perinatal outcomes are worse after 41 weeks. It's probably related to subtle changes in placental function and therefore lower tolerance for the fetus for the stress of labour. And this has been known for a long time. We've always known that there was that slight increase in stillbirth, but sort of accepted the risk. And I think the guideline group now decided that really we should be sticking to the evidence and having that discussion. And I'm sorry that it has caused a bit of controversy amongst members. There's no clear gestation where the risk really becomes significant. So that makes providing, a definitive cutoff in a guideline quite difficult. There are also only a few studies that really look at CTG and how it performs in the setting of individual risk factors. So that's why the guideline presents the evidence for CTG as indications based on risk factors. I just want to make clear that the guideline group were not intending to make a guideline to define inclusion criteria or indeed to define service capability. We were making a guideline for intrapartum fetal surveillance. So what we hope is that various services will use our guideline to create their own criteria for inclusion. And of course, service capability is very individual to each particular specific service based on geography and local expertise and various supporting services. So, our hope is that this evidence-based guideline will help people in those circumstances actually make their own conclusions.
Yeah, and I think those individual conclusions are important, aren't they? And if we hark back to what we said earlier about women making informed decisions and shared decisions about what form of monitoring they would like to have in labour and knowing what facilities are available in each of their models of care, then I hope this guideline will help them have those conversations.
Yeah, absolutely, Scott.
One of the other things that's new in this guideline is the use of CTG in the case of very preterm babies. What does the guideline say about that?
Yes. So in my role in Stillbirth Committee, I've been aware of a few incidents that have occurred because of misinterpretation of preterm CTGs, and they can be quite complicated. So I'm hoping that clinicians will really welcome our attempt to put together CTG parameters based on gestational age. The specific parameters for preterm CTGs are a bit limited, but the guideline does give some general areas which are commonly accepted. And there's also the suggestion that for preterm you should use the fetus's CTG as its own benchmark. So obviously a change in baseline or a change in the variability of the CTG could be considered significant.
The moments, the connections, the memories and the learning. I think that is the 4 things that will bring me to any symposium of RANZCOG. The connection that we make with each other and the connection that I feel towards the college the connection of belonging to the college and the community. Then would come the memories I make with friends, sharing knowledge, talking to each other, making new friends. And the last, not but the least, would be the learning. We all learn from each other, we share ideas, we get to know what is out there, we get to know about new things.
One of the things that we spent a lot of time talking about in the meetings during the guideline development was fetal sepsis and sort of non-hypoxic changes in CTG. What does the guideline say about that?
Fetal sepsis is so significant because all neonatologists will tell you that for two neonates born at the same gestation, but one with sepsis and one without, the one with sepsis will definitely do worse. So if you have any suspicion that the fetus is mounting an inflammatory response, you must expedite delivery. And that's partly what the guideline says, to always consider sepsis, both maternal and fetal. Expedite delivery if there's any suggestion that the fetus does have sepsis. And of course, fetal blood sampling, scalp electrodes may be contraindicated. Well, the fetal blood sampling is definitely contraindicated, but the scalp electrodes may also be contraindicated if, again, you suspect that sepsis is present.
What are the recommendations for the use of acute tocolysis in cases of prolonged deceleration, other severely abnormal CTG patterns?
Yeah, so the guideline, we spent quite a bit of time discussing tocolysis as well, and prolonged decelerations over 90 seconds and up to 5 minutes can certainly be associated with fetal compromise and require action as listed in the guideline. Excessive uterine activity is present, abnormal fetal heart rate patterns. You can consider tocolytic therapy, provided there are no contraindications. And very important to consider always are there any contraindications such as suspected abruption, suspected uterine rupture, maternal medical conditions, allergies, fluid overload, any other reasons not to give tocolysis. Of course, it shouldn't be used, but it is definitely worth considering, especially in the presence of excessive uterine activity. We couldn't make a recommendation on the safest drug. The evidence is lacking. So we think it's most important that a service puts together their own recommendation, settles on a tocolytic and includes a guideline for that so that the whole team knows what to do and can easily access it.
Another change in the updated guideline is the inclusion of fetal scalp stimulation as an alternate method for assessing fetal well-being in the context of an abnormal CTG that doesn't require that immediate expedited birth. What does the evidence say about fetal scalp stimulation and about fetal blood sampling?
Yeah, I thought it was really interesting to include this. Thousands of years ago when I was a trainee, we used to do the vaginal examination and always look at the CTG through the VE and often comment afterwards, oh, look, there was good excitation. But it was never done in a kind of formalised way. It was just part of our overall assessment. So the suggestion here is that services might choose to actually formalise this response and include it as a low-resource, low-cost, easy-to-perform test of fetal well-being. Unfortunately, the evidence for fetal blood sampling is sadly quite scant. But look, it can be an appropriate test where you're genuinely looking at a CTG and thinking, I'm not sure what this is trying to tell me. It is, when it is normal, it is a very reassuring test to exclude hypoxia. I think the only other feature about it is that it was always kind of designed as something to put you through the next, to get through the next couple of hours if you foresaw, that there would be a major change in the ability to deliver this baby in the next few hours. So something else to consider when you're thinking about doing a fetal blood sample.
You led a trial of fetal blood sampling and that trial was negative. It didn't show a significant improvement in outcomes in fetal blood sampling. That doesn't mean it's not worthwhile, does it? And we spent quite a bit of time in the guideline development group saying, look, we genuinely believe this is a useful technique. So why were the studies negative?
Yes, that study, unfortunately, somewhat underfunded and we had major recruitment issues. And I think this is one of the problems for all of these studies of CTG, intrapartum CTG particularly. You're recruiting in the the birth suite environment. You've got to recruit beforehand, but then you've still got to gain consent right at the time that women are in. And then judging whether a CTG falls into that some abnormalities but not a clear indication for delivery category is also quite difficult. So, you end up with quite a small pool to be able to recruit to, and then so many say no. So sadly, we did not reach our target recruitment in that trial, and I think that's part of the reason why we had a negative result. And really the point of the trial was to try to generate evidence for fetal blood sampling, but we didn't succeed.
Yeah, it speaks to the difficulty of doing research. This is a seriously difficult research environment to work in. Women in labour, lots of consent issues around, shades of grey of CTG interpretation, and it makes it really quite challenging to write a guideline where the evidence is not particularly clear one way or the other.
Brave researchers who try to work in this area, to be perfectly honest.
Well, speaking of research, let's wrap up talking about some of the newer technologies that we've addressed in the guideline. What are some of those more recent fetal monitoring technologies, and what does the current evidence show about them?
New technologies, we've got fetal ECG analysis, we've got fetal pulse oximetry, computer decision aid CTG monitoring, and then maybe in the not too distant future, AI supported decision-making interpretation. So of those, fetal pulse oximetry and the computerised ST wave analysis for the fetal ECG really haven't got past the research stage. So they're not recommended in the clinical settings at the moment. Unfortunately, again, the trial that's out there of the computer decision age CTG monitoring, the infant trial, lots of criticisms of the method, maybe some confounding because it was done, on the same birth suite. It was a negative trial. So again, at the moment, I can't say that the evidence is really supporting the use of computer decision aids for CTG interpretation. A really AI, machine learning based system is not yet available, is the bottom line. We all think that maybe that sort of system might be of benefit because of the non-variability with interpretation of CTGs and how it's so dependent on people picking the factors that are significant in it, but not yet available. So we'll wait with great enthusiasm.
Great enthusiasm. We wait with bated breath.
Yeah.
Happily, there's some light on the horizon, aren't there? I mean, you and I have done some work looking at continuous fetal lactate monitoring, still in a research phase, but something that shows quite good promise. And an AI interpretation of CTG, like most things in the world, AI will take over. And there is certainly some evidence for some really great work being done locally in Australia that shows, the real promise that AI interpretation has compared to the more basic computer-assisted CTG that's not been shown to be of benefit. So,
yeah, I'm looking forward to it.
Penny, thanks for your great contributions today. Before we finish, is there anything that you'd like to share as your key takeaway for the audience?
From an improvement point of view, we're always really keen to standardise care. I hope this guideline will contribute to services offering the same care and the same kind of care and the same kind of opportunities to women anywhere in Australia.
Great. I'd like to give a plug for the Fetal Surveillance Education Program, RANZCOG's flagship education program. FSEP's been around for now a couple of decades and has been one of the few CTG training programs that's actually been shown to improve clinical outcomes. So for those of you who are looking at more education in CTG interpretation, then I can commend RANZCOG's Fetal Surveillance Education Program to you.
And I think the last time I did FSEP, they included some work on situational kind of judgment, which I thought was a great advance as well.
Exactly, FSEP. Yeah. Those human factors, the things that are difficult to encapsulate in a guideline, but is so important in a multidisciplinary labour ward environment. And Penny, thanks for sharing your insights. You can access the RANZCOG clinical guideline for intrapartum fetal surveillance via the link in the show notes. If you enjoyed this episode, please rate, review, subscribe and share. And don't forget, RANZCOG members can log CPD hours using the form attached in today's show notes. We'll be back soon with more essential conversations on Talking O&G.